All right, we're going to get into sepsis for this lecture. We're going to go through our entire protocol for sepsis and how we treat it, the pathophysiology of sepsis, the difference between SIRS, sepsis, septic shock, also some of the CDC data that's out there. It's pretty interesting and is very applicable for healthcare providers and specifically pre-hospital healthcare providers. So our objectives are pretty straightforward and very similar to what I just said. We're going to understand what sepsis actually is, the difference between SIRS, sepsis, and septic shock, and then how we treat them. So getting into a little bit of what the CDC says about the data, according and specifically to sepsis, is 80% of the cases are found pre-hospital. So that means we are hitting a very high majority of these folks. Now, whether we catch them all, that's a different story. But more often than not, when we have, or when the hospital sees a sepsis patient, they were sepsis when we got them. And that's important for us to understand, I think, because that's a big chunk of people. 1.7 million adults develop sepsis each year, and then 270,000 Americans die each year from this. So it's a big cause. I lump it right in there with strokes and heart attacks, trauma. It's one of the ones that we need to be really good at recognizing, or try to be really good at recognizing. There's going to be some that are going to trick us and slip by us because it was just that patient happened to present just a little bit differently that time. But for the most part, this is one that we should really focus on and really try to memorize and be really good at this one. So who's our target population? Well, our target population is the young, the old, and the compromised. So we talked about geriatrics recently, 65 and older, less than 1 year old are young. And then the compromised is anyone with a chronic medical condition or someone who has a suppressed immune system for whatever reason, born with it, developed it over time, the unfortunate victim of an accident. It doesn't really matter, is they become more susceptible to having this infection that systemically forces their entire body to react and overreact, really. So most people that have sepsis are 65 years or older, or they're less than 1 year of age, and they have an immune system that's suppressed, or they suffer from that chronic medical condition. 90% of those adults that are 65 years or older had an underlying health condition, and then 70% of the children who developed sepsis had an underlying health condition. It's pretty staggering numbers. So if we go into this looking like we get any run, it doesn't matter what we're dispatched for, and we get there and we start to suspect sepsis because of some of the criteria that we're going to talk about in a little bit, probably the criteria that you guys have memorized, because this is a big one for us, and I think we're really good at sepsis in general. But we go in and we realize that this person is young or old, and they have a chronic medical condition. It's a high likelihood that they're going to or are already in sepsis. They're meeting not just the vital signs, but they're meeting the demographic population that the CDC collects data on, which can be helpful for us. It's kind of like a pre-plan. If we can be ready for it before it ever happens, I think that's a good thing. It allows us to make our aggressive treatment that much faster, probably. So now we're going to get into really the sepsis cascade. So this is SIRS, so the Systemic Inflammatory Response Syndrome. As you can see there, that little snapshot is from our protocol, the 2020 Southwest Ohio protocol, and it probably should look really familiar to how we start thinking about our septic patients, right? This is the ones that we really hit on really hard when this became a protocol. Well, this is a SIRS patient. This is someone who has a systemic inflammatory response in their body, and that's what it is. That's all it is. And we're going to talk about the difference between this and sepsis, because someone can have this and not even have an infection. It may be from something else, and we'll get into that in just a little bit. But for someone to be considered a SIRS, have that systemic response, they need to have at least 2 of the following vital signs. Top one here, temperature, high or low. We're going to talk about that more in a little bit. Hypotension. Protocol does a nice job of laying out vital signs for us when we get into our pediatrics. That stuff's hard to memorize. No reason we can't use that to our advantage. Heart rate, greater than 90. So the thing about heart rate for anybody is that it needs to be sustained. So when we have it for adults and their heart rate's greater than 90, and they tend to fluctuate, and I know here it says sustained tachycardia for age and pediatric patients, just realize that if someone just ran a marathon, they're probably going to have SIRS because they just did a 26-mile insult to their legs, right? So that is what it is. It's an inflammatory response that needs to be. If it's not going away, then we have an issue. So just understand, just make sure you know that when you're counting the heart rate as one of them, make sure that they didn't just do some strenuous activity. Same for respers, really. But so our respers, 20, greater than 20, and then tachypnea, and for the age of pediatric patients. Altered mental status confusion. I feel like we say this in almost every training, but it's good to constantly remind ourselves that when a patient has an altered mental state, that's not good. That should be a big clue for us, regardless of what's going on, and it should really hopefully pique our senses as to maybe something really bad is going on, and we need to dig deep until we find out what that is. So that's SIRS. We're going to move over here to an infection, and we're just going to talk about an infection just for a second, because it's important for when we're talking about not only the Southwest Ohio Protocol and sepsis criteria, but it is very important to distinguish between SIRS and sepsis. So an infection occurs when viruses, bacteria, or other microbes enter the body and begin to multiply. More often than not, hopefully, the body beats that when they begin to multiply, because we send white blood cells, we have a small inflammatory response, our body does all the things it normally does to react to such an insult, and it wins. That's how the body's designed. That's what we hope to happen. Hopefully EMS never gets involved. Unfortunately, that's not always the case, obviously, because we have jobs, right? So these are infections, common infections that we see in our folks who are not very mobile. We don't have nursing homes, obviously, a lot. We have one, but they're coming, and we have geriatric patients. So someone who's not moving a lot or not being rolled like they should be, they can get pressure sores or bed sores, and that is a pretty common cause of developing sepsis, and obviously having an infection where we don't want it to. So also, it can be kind of easy to miss. So when we're trying to cycle through our differential diagnoses and we're trying to figure out what's wrong with our patient, and they're meeting our SIRS criteria, but we just can't find that source of infection, it could be as small as something like this. And they get them all over the place, on their heels, sometimes in their groin, on their buttocks, at the top of their buttocks. It can be tough to find sometimes, but we got to do our best that we can and really try to focus in on this. So here's sepsis. Sepsis occurs when we have chemicals that are released into the bloodstream to fight an infection and trigger an inflammatory response throughout the body. So the most important part about all that is it's throughout the entire body. So we are looking at an inflammatory response from stem to stern. Every part of the body is being affected. And we're going to talk about not just sepsis, but the next stage, because we're going to talk about the differences between SIRS, sepsis, and septic shock. When we get into septic shock, and when someone goes untreated and the body is allowed to continue to kind of spiral out of control and they become septic shock, it really starts fighting against itself. And that's not good, especially when it's happening all over the body. It's very hard to recover from that. So let's combine them all together here on one slide and just talk about it just really briefly, just to kind of sew things together for us. So we have SIRS here. So this is our SIRS, our big inflammatory response, that is not caused. This yellow portion here isn't caused by an infection. It's caused by other things. If you slap your arm right now, you're going to have a very local inflammatory response. Your body's going to react to that. Anyone who's ever had any sort of trauma knows that. Burns do the same thing. Sometimes when we have localized inflammation, because pancreatitis is listed here, but we could have all kinds of insults, kidney stones, surgeries, lots of stuff to where a patient could present with those SIRS criteria, but they may not necessarily be going down the road of sepsis. Because to have sepsis, they must have a source of an infection. Okay? And that's why these two cross over here. So if we have our infection side, we'll look back on our other side, or one of our previous slides, and we start to think about all the different things that can cause this. Obviously, the bacteria is really big, right? That's our most common one. But it could be any microbial, from a fungus to a virus. And that infection source, now they start to present with SIRS criteria. Now we're starting to fall into the realm of sepsis. And that's where we are coming into play probably. Because, yeah, they were sick for a week or so, thought they were getting better. They weren't getting better. Nothing's working. It's getting worse and worse and worse. We woke up and, mom or dad's just not feeling good this morning. They're just not acting right. And that's where we come in. We come in, the house is hot because they got the heat cranked up because the patient's sick, and they're trying to compensate for that because their body's been compensating for how many days now. And then we get that 80% mark from the CDC of found pre-hospital, we have a septic patient. Now we got to do something about it. So some of those causes, linking back to that previous slide, for those infections, we're looking at some, and this is off the CDC website, but these should look pretty familiar for us. Staph, strep, and E. coli. All things that most all of us have heard of, or unfortunately might have had. Pretty common bacteria. And then you roll down into these percentages here, and 35% are lung infections. Then you look at urinary tract infections. That's the one that a lot of people think of, right? Most commonly in females. And then you have gut infections, gastroenteritis, diverticulitis, skin infections, those pressure sores, bed sores. All these add up to be a high percentage. And then now we can really start focusing our search on where our source is, because we have to have that. We're going to talk about why having a source is so important when we get into the actual protocol part of this lecture. So if we know that these numbers all right here are the vast majority of what we're looking for, then hopefully that can kind of cue us into, have that pre-plan in our head. Like, all right, this looks like a septic patient. What's their history? What's been going on? And then we can really focus our assessment in those key areas. So this is a slide from the Khan Academy. Khan Academy is all over YouTube. It's a really good resource for us to use when we're talking about pretty much anything medical, or they're really good. It goes in a little more depth than what maybe EMTs and paramedics need, but nonetheless, it's very good. So we've talked about SIRS, we've talked about sepsis, and then sepsis we know is all our SIRS criteria plus having an infection, and then sepsis transfers into septic shock. And septic shock is basically untreated infection that got into the bloodstream and is now systemically attacking our body as a whole. So to walk through this, and I'm guessing some of you or most of you probably know what I'm about to say, but for some of the newer folks, let's roll through this, and it'll probably be a good refresher for some of the older folks. So if we look at our blood vessel, that's what this is. This is a blood vessel. So if we look at our blood vessel here, let's pretend that everything is at this 2 red lines here. Our yellow boxes represent tissue and cells that need to be perfused. Okay. This is our interstitial space. This is our extravascular space. So now we have kind of a quick rundown of anatomy. These are our red blood cells. Our little white circles are going to be our white blood cells. Pretty straightforward. And I'll describe the purple here in just a second. These little green guys, that's our infection. I'll probably end up saying bacteria a couple of times, so we'll just roll with bacteria. So we have a bacterial infection in the bloodstream. The body does what it normally does. And the first thing that the body does when we come into contact with an infection is to travel through the bloodstream, get to the site where they think it is, and do its thing, and start eliminating the threat. Well, unfortunately, bloodstream infections are pretty rare. They only happen when someone has not been treated and they've not been doing well. More often than not, infections happen out here in the interstitial space. So the first thing that a white blood cell or a group of white blood cells has to do is to make it into the interstitial space. Well, unfortunately, that's pretty tough to do through a solid blood vessel. So a white blood cell will do the first thing that it needs to do to reach that. It's going to release nitrous oxide. It dilates our blood vessels. So now our blood vessel becomes this big. Becomes more permeable. Becomes a little leaky. Normally, what should happen if the infection is out here in our interstitial space, beyond our cells that need perfused, the white blood cells now have the access to go into the interstitial space, release its enzymes, hopefully destroy the bacteria, and then the body has done its job. Everything goes back to normal, you start feeling better, everything worked like it was supposed to. That's not what happens here. Unfortunately, what happens is the white blood cells reach the point of the insult, which we're looking at a very small picture of a human body right now. They find some bacteria, so they permeate, they dilate our blood vessels, thinking that they're going to find infection beyond the interstitial space, which is what they're designed to do. They also come into contact with bacteria in the bloodstream, so now they immediately start releasing those enzymes. So a couple things happen here. So with our dilation, without ever doing anything else, without even accounting for any of the fluid that leaks out, we made our tank bigger. And this is a small snapshot, but if we look at the whole body, and we just made our tank bigger, we have a drop in systemic vascular resistance, which they were kind enough to put our blood pressure equation right here for us. Cardiac output times systemic vascular resistance equals blood pressure. So if we have a drop in that, we have a drop in blood pressure. Hypotension, right? Shock. What is shock? Shock is inadequate tissue perfusion. Hypotension's a big culprit of that. So we're leaking volume. That's a problem. That becomes the hypotension. And then now we are looking at our fluid interrupting tissue perfusion as well. So this blue stuff here is representing the fluid that's now leaking out around the tissues. So now we have these enzymes floating around trying to destroy bacteria, and we have white blood cells here, but we still have red blood cells. Red blood cells are still carrying oxygen like they're trying to do, hopefully, and they're trying to push it into the places that they need to go, which are our cells and our tissue to perfuse it, to keep our body running like it's supposed to. Well, with all this fluid here, it gets in the way. And they have a hard time and a much slower uptake of that oxygenation becomes a problem. So now we have two things working against our definition of shock: inadequate tissue perfusion, low volume, and when finally the oxygenated red blood cells get there, despite the low volume, they're having to wade through all this extra fluid that's not supposed to be there. So now we have a double whammy. So that is the signs, the vital signs that we are going to see probably immediately. These are the bad ones, like that really jump out at us. We come in the house and this patient might be pale and they're hot to the touch, and maybe they're cold to the touch. And we'll talk about cold in a little bit when we get into the protocol. And then we find this source. They have a bed sore, they've had it for a while, or they just had this really bad cough for a couple of weeks, and doctor said the pneumonia went away, but maybe it didn't quite go away. Whatever happens to be, and now they're starting to show symptoms of decompensated shock, maybe. Because that's probably where they're at. If they're reaching this point, that is likely when we are going to get them. The earlier we catch it, the better. But more often than not, they let it go a little too far because we're all a little bit stubborn and no one wants to go to the ER. But this is probably where we're finding them. If we find them in later stages of septic shock, what we'll find is number 3 here: damage. And what damage means is these enzymes finally are going to eventually miss a bacteria, or there's an abundance of enzymes because this is happening systemically across the body. And now we're having damage done to the vessels themselves. And that's what these holes here represent, and that's what these purple things are. So the dark purple lines are clots. That's a problem. We have obviously damage to the vessels, so the body does not want to lose blood to the extravascular space out here, so it starts building clots. Some of them break off because, well, there's enzymes in the blood. So now we have clots breaking off, and we have blood leaking out into the extravascular space, into the interstitial space, and all the places it's not supposed to be. And most often than not, this is what we will probably end up referring to as MODS. But this coagulation complication is called, and this is not something you need to remember, but it's disseminated intravascular coagulation. It's a problem. We're having issues with our vessels breaking down at the wall, leaking stuff out. It's trying to coagulate. Some of them break off, some of them don't, some of them re-break down from all the enzymes in the bloodstream, and it's a vicious cycle. As this happens throughout the whole body, instead of just this small snapshot here, you're looking at MODS. MODS is multi-organ failure. This is why. They're fighting against each other. We're losing blood, we're throwing clots. Maybe we're throwing clots in the renal system, in the liver. Liver's breaking down. We are having PEs now. Maybe we have a septic patient who was very confused suddenly. Maybe they had a stroke, and that was secondary to their septic shock because they've developed all these bad things. Focus in on the respiratory system, and all this is happening there also because there's blood vessels there, right? And we look at that, and that's where ARDS comes from, or acute respiratory distress, because everything's happening there. We may get a PE, blood backing up into the heart, fluid getting in the way, fluid backing up in the lungs. Now not only are we having issues here at the interstitial area, and we're having issues with cellular perfusion there, now we're going to have issues with respiration. That cellular transfer of oxygen and carbon dioxide in the lungs is now having a difficult time. So now we are 3 knocks against shock. Now we're 3 knocks against it, inadequate tissue perfusion. Not good stuff. So hopefully this was a nice, good reminder of what septic shock is and how it affects the body and why it's so bad. And now you truly probably understand why it's called a distributive shock. Because it distributes all the fluid, without ever leaving the container throughout the body in places, and it still causes lots and lots and lots of issues. So as we jump into our protocol, what we're looking at here is the top part of every protocol has an inclusion criteria. And the inclusion criteria basically is, does this patient fit the differential diagnosis for us to treat them under this protocol, right? So looks pretty familiar. So all ages, obviously this could be pediatrics or geriatrics, and we know that pediatrics less than 1 year of age who have a chronic medical condition or a suppressed immune system are 70% susceptible to this. Even higher for adults, geriatrics. So all ages. Suspects infection. This becomes even more important as we move on into the next slide, because for us to call a sepsis alert, we have to meet some certain criteria, and that's one of them. So adults at least have one of the following abnormalities when we talked about these, and they should look really familiar, which is nice. Blood pressure is low. Heart rate is high. Now 90 is not really high for what we typically consider tachycardia, but for this patient with all the other signs and symptoms that they may be displaying, that is relatively high. Visible tachypnea, they're breathing fast. Altered mental status is always bad. In our pediatrics, and then we have sustained tachycardia, tachypnea, cool pale, skin, delayed cap refill, altered mental, bad peripheral pulses, and then they have the bounding pulse where the kid gets really warm, and you see this especially during bronchiolitis season where they have that really bounding pulse because they're just not feeling good. They're coughing like crazy, and that one's a pretty easy one to recognize. So we have this big list of inclusion criteria, and it looks probably pretty familiar to what we talked about at the very beginning, which was SIRS. So this is SIRS criteria. So now we're looking at them thinking that, okay, maybe they're having an inflammatory response of some sort based on our assessment. So what do we want to do? Well, what do we always do with all of our patients, right? We put them on N-tidal. We want to monitor that because N-tidal tells us a lot, and it gives us some really good things, especially when we're talking about tachypnea and they're breathing fast. And then when we get into the next slide, it talks about N-tidal levels specifically, but N-tidal is really good for us to monitor, and it's real time. It's based on what the patient's doing at the moment. Get a temperature. So I'm going to get my coronavirus outlier that I feel like I have to mention in every training. Temperatures right now. So we want to do a temporal temperature. We are avoiding doing oral temperatures at the moment to limit our exposure to any fluid or droplet transmissions into our eyes, mouth, under our gloves. So for now, and remember, we're dealing with a potentially infectious patient here, and we don't know why. We don't know if they have corona. We don't know. So please take a temporal. I know that there's plenty of studies out there, and it's even in the protocol that axillary and oral temperatures are better. But for the time being, we need to stick with our temporals for our safety. There's plenty of other vital signs that we can look at and link up with a temporal temperature based on what our patients are probably presenting with. Always get a finger glucose stick with someone who's altered at all, and it should almost be a normal vital sign by this point. Okay, now we're going to flip over to the next slide, which is just, if you're following along with the protocol, it slides right into this after our previous slide, and this is the pre-hospital notification of a sepsis alert. And then now we have gone beyond just the SIRS criteria and said, okay, this person is sick. These are probably at the beginning stages or maybe our deep stages of septic shock. These are the folks that need our aggressive treatment because they are now not compensating well. Okay. These are the folks that really need our help and the ones that we have to be aggressive with our fluid administration and our potential push dose epi. So to do a pre-hospital notification, again, we have to suspect and know that we have a source of infection. In title, at the very end, it was very specific that we want to put these folks that we suspect of the criteria on entitle to monitor it throughout our transport, and this is why. We have an infection, and then we have them on entitle that's less than 25, and then we couple that with 2 of these vital signs right here. Look very familiar. We have a temperature, high or low. They're hypotensive. Their heart rate is high, above 90. Remember, it needs to be sustained for pediatric patients, really sustained for all patients. Respirations are high, and they have an altered mental status. So we have an infection, their end tidal is less than 25, and then 2 of these other vital signs. And now we've met the criteria for a sepsis alert, and more importantly, we now know that this patient is really sick. And maybe they're handling it really well. Maybe they are tough old granny and they never get sick and they're fighting it off the best they can. But on the inside, we've already talked about what's happening to them. Think back to that slide where we broke down what happens to the body when they have the systemic reaction that triggers everywhere in the body. These vital signs are a result of that. And that should cue us into, we need to be aggressive and we need to really make sure that we are throwing everything we can at this patient to do the right thing for them. Because they're going to need to be treated aggressively, and a part of that is making sure that we make this notification right here. We have got to let our hospitals know that we are coming in with a sepsis patient and where their body is failing them. Be very specific when you call this, like, hey, yes, their entitles this, but they also have these vital signs. They're hypotensive, the heart rate's very high, they're respiratory in distress, and they're not making much sense when they talk to us. That's affecting the entire body. They want to know that. They're going to get prepped and to treat this patient even further down the road than maybe what we would normally do. So if we talk about very specifically, just for a second, about temperature. So high temperature is typically what we all think of as when we see someone who has an infection in general, like, they spiked a fever. Right? In our kids, they spiked a fever too fast and they had a febrile seizure. Well, that's 100% applicable, but don't overlook the fact that sometimes they can have a low temperature, and a low temperature is typically going to be our patients who are not doing well at all. Those are our late stage septic shocks going into that part of the slide that we talked about where we are seeing lots of damage happening to multiple organ systems, and they're not compensating very well at all, most likely. They are losing that compensatory factor, and that is why they are cold. So just keep that in mind, that if you find that person, you really need to get a move along, take some extra people with you, and throw the card at the patient, really help them out. There we go. Sorry about that. So if we get the sepsis alert criteria met, this is a part of that acting aggressively and treating aggressively. We want to establish an IV or an IO if indicated. We need to get access to give fluids, right? And obviously we carry warm IV fluids. We've talked about multiple times why warm IV fluids are great. They're really only bad for our hyperthermic patients. Obviously this is hyperthermic because of an environmental cause, not because they have a fever, right? They're not that hot. So we need to get some IV fluids on board. So it has our dosing here for us, which is really nice. Sets it up pretty easily. So once we get that access going, it's 30 milliliters per kilogram. maximum of 500 milliliters per dose. So if you're giving your first dose, and we'll talk about the 30 milliliters per kilogram in just a second, but the max is going to be 500, and then that's going to be over less than 15 minutes. And then they get a nice mention of push-pull method here. We all know what push-pull method is. Try to use a 20 ml syringe if you can, and that's definitely preferred for our pediatric patients. Our pediatric patients are among the target population that if they have a chronic medical condition, obviously they could be the ones that are going to get this more often maybe than you or I. And then we can repeat that dose for the specific patient 3 times to a total of the maximum of 1,500 milliliters based on the patient's condition. How are their vital signs improving or not improving? And then our clinical impression of what we think is happening for our patient. So if we jump back up to the dosing here, since this protocol is meant for adults and pediatric patients, it makes sense that they have this right here. So to give you just a little bit of a clue, and you've probably already done it in your head really quick, but our patient for that, like the max that meets the 500 milliliters off the rip, is between 16 and 17 kilograms. So if you did the math really quick in your head, that's between a 35, 36, 37 pound patient. It's not very heavy, right? So those are our toddlers, our 2 to probably 4-year-olds, just depending on how much they weigh and how much they eat and just how different of a human being they are. So that's where you're looking at for those folks that are going to be. Anyone who's smaller than that is where you really need to know this number for them to start aggressively managing their distributive shock, and probably that's decompensated at this point because we've reached the sepsis alert point. They're not showing good vital signs. Do not delay transport to initiate IVIO or fluid bolus. I can get on my soapbox if I wanted on this, but I don't really think there's a need to, because I just don't see this often. You know, these are definitely not the folks that we want to be sitting on the scene with. We should be loading and going, starting IVs en route, and treating this person aggressively and notifying our hospital that we are coming in with someone who needs definitive treatment. And we should not delay our transport to start doing these things. We should be doing this stuff en route. Okay. Push dose epi. Here's a quick reminder on this. This is really besides fluids, the only other thing that we are able to deliver in order to treat our patients. So we've gone over this a couple times, but again, it's not a bad thing to go over. So the actual dose of what we're giving here, once we've made the mix, is 0.5 to 2 mLs of a 10 microgram per milliliter solution. And we're going to give that every 2 to 5 minutes, or if you've heard me say, really every 2 minutes until that person is starting to show improvement in their vital signs, right? So that is the whole point of us giving a pressor. We want to make sure that we are beginning to raise our blood pressure, whether it's through fluid resuscitation or pressor resuscitation, that we're raising that pressure to save those 4 organ systems that we have to save. We have to perfuse them, or in the end, we have done them not a whole lot of good. Brain, lungs, heart, and kidneys. We got to get those. So that's the actual dose. I think to make your life really easy, I personally would pick 1 or 2 mLs and then titrate from there to make just your dosing just a little bit easier on yourself if you've never given this. And then mixing it, I just snipped off method 1. There's 3 methods. This is method 1, and I feel like this is the one that most people do when we're doing it. And then obviously there's an extra step added in here that can't be really taken into account of, and that is because we don't have premixed epinephrine as the cardiac dosing so we don't have those carb ejects anymore. So what we got to do is take that pre-set up epi in the drug bag in the main pocket there, pull it out, mix it like we were going to run a cardiac arrest, but then we need to further dilute it. And that's what this method is here. So once you mix your cardiac amp in that main pocket there, then you need to do this method right here. So hopefully that makes sense. If not, get with your partners, talk over how this needs to be done, because this is not something that you want to run through, and this is something that's really hard for me to show you on, obviously, this pre-recorded training for you, but this is a double dilution for us when we're talking about mixing our push dose epi. Please go over this, review this, talk about it, and if you have any questions, do not hesitate to reach out to me, and I will put together an even shorter video of how to do that with some training materials that we have. Use stopcocks; those are great for making multiple doses of this, make your life a little bit easier. So the big takeaways that I want you guys to get from this training here is that we, as EMTs and paramedics, have a very high chance to see sepsis. 80% of them are pre-hospital. We're not going to get them all because not all of them present perfectly and say, I had a UTI this week and now I don't feel good. I'm hypotensive and my entitle is less than 25. Not all of them, unfortunately, do that for us. Some of them can be a little bit tricky, and they could have multiple things going on because depending on what level they are and how the body is reacting to this systemic response, they could have other things going on and they could present other ways. And based on what the family tells us, how good of historians are they? You know, how many they've had previous strokes. I think this is a stroke. This is the way he acted the last time he had a stroke. We can get led down a path. But don't ever let this one fall off your radar. And I feel like we do a really good job with this, but I think this is one that it's good for us to just get a good reminder on it. Be aggressive when you treat septic shock. And honestly, septic shock, really, I should have put aggressively treat sepsis alert patients is really probably what I should have put here. Because when we reach our sepsis alert criteria, those patients, as you can see, their vital signs are right on that cusp of not being normal. And as we all know, no one's ever 120/80, right? So just when we get our sepsis alert patients, no one's ever right at that 90 heart rate or right at 25 capno, right at 20 respirations. They're always much higher than that or much lower than that, depending on which way the bat is, the swing. Unless the family's just really good and understands that their relative's getting sick. So just be aggressive. Treat those folks. Fluids are good. Push dose epi is good. Don't be afraid to bump that out if everything else isn't working. Remember, the total fluid volume that you can give a patient is 1,500, and then go over doing push dose epi, and then don't forget the sepsis alert. Sepsis alerts are so important to give our friends at the ERs a heads up of what they're about to walk into. They don't really have a choice to take it, but I mean, we got to give them the best chance to make the difference for this patient. I hope you enjoyed it. I hope you learned it. As always, please take the test, sign a roster, and then fill out an EMS evaluation. That should all be in the email. Thanks.